Hello, good morning, good afternoon, and good evening to all the speakers, chairs, and wonderful audiences in different parts of the world. Welcome to the ACNS webinars. The speaker for the first section of today is our honorable guest from Iran, Dr. Poria Mosayadi. Dr. Mosayadi is a vascular neurologist and neurointerventionalist, the assistant professor of neurology at the Tehran University of Medical Sciences in Iran. He did his neurology residency at the University of Pittsburgh Medical Center under the tutorship of Tudor Jovin and Asudas Jafar. He did his vascular neurology fellowship at the University of California, Los Angeles, mentored by Jeffrey Silver and David Levitsky, and the neuro and vascular surgery fellowship at the Mount Sinai School of Medicine under the mentorship of Alejandro Berenstein and Jay Mokro. He worked previously at the Jamaica Hospital in New York City and returned home and joined the Tehran University of Medical Science as the assistant professor of neurovascular diseases. He's a local author with several publications in various peer-reviewed journals. He started creating videos on the basic concepts of neuro and vascular surgery and organized them into playlists on his YouTube channel. We're extremely honored to have him today with us as a speaker for our webinar, and today he's going to talk about the basics of cerebral neuroangiography. The speaker for the second section today's webinars is our honorable guest from China, Professor Chuan Kai. Dr. Kai is an attending neurosurgeon at the Huashan Hospital in Shanghai, China. He accepted clinical neurosurgical training on cerebrovascular disease surgery, skull-based surgery, endoscopic surgery. His research is mainly focused on neurosurgical treatment, epidemiology, and pathological mechanisms of cerebrovascular diseases, such as aneurysm and arteriovenous malformation. We're extremely honored and grateful to him for accepting our invitation to be our speaker at our webinar. And today, we'll be talking about comprehensive surgical management and one-stop reconstruction of skull-based tumors. Insights from Huashan Hospital. The chair for the first section of today's webinar is our honorable guest from USA, Dr. Mohsen Nourik. Dr. Nourik is the director of cerebrovascular interventional neurosurgery at the Jamaica Hospitals in New York, USA. He's a hybrid trained neurosurgeon who specialized in stroke and cerebrovascular diseases. He was a former fellow at the Fujita Health University in Japan. We're extremely grateful to him for accepting our invitation to chair the section of Dr. Poria Mosayadi. The chair for the second session of today is our honorable faculty from UAE, Dr. Tarek Brian. Dr. Tarek is a consultant neurosurgeon of cerebrovascular and skull-based lead in the Strasbourg Medical City SSMC in Abu Dhabi. He was previously a consultant neurosurgeon and associate professor of the Department of Neurosurgery, Alexandria School of Medicine, the University of Alexandria in Egypt. He was a member of the Young Neurosurgeons Committee of World Federation of Neurosurgical Surgeons, WFNS. He did his clinical cerebrovascular fellowships from the University of Illinois and at Chicago, followed by international neurosurgery clinical fellowship from the Mayo Clinic, Rochester, in Minnesota and USA. He was also a skull-based neuro-oncology cranial neurosurgery fellow at the Mayo Clinic from 2015 to 2016. He's a looked author with several publications in various peer-reviewed journals, and we are extremely honored and grateful to him to accepting our invitation to chair the section of Dr. Chuan Kai. On behalf of the Educational Committee of ACNS and the President, Professor Yoko Kanata, I would like to welcome both the speakers, chairs, and the audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and I'm extremely thankful for Professor Shubi broadcasting the webinar on the WeChat channel. With that introduction, I would like to hand over this online podium to our first chair, Professor Mohsen.
Hi, good morning, good evening, everybody, ladies and gentlemen across the world. It's utmost honor to be again as part of ACNS, and have special thanks to all the members of Education Committee, and of course my dearest mentor, Professor Yoko Kato. I'm very happy that we are hosting a session about basics in neuroangiography. This is one of the things that usually is dismissed in most educational workshops, meetings, and conferences, and everybody's talking about complex procedures. And sometimes forget that how important these basics in angiographies are, and how they may affect the outcome of our procedures and, of course, consequently, our patients. Again, at the same time, I'm very happy that this is being handled by Dr. Mashadi. I know him for decades, and I know that he's done a very great job at creating a small atlas, online atlas that is accessible to everybody by teaching the basics of angiography. I'm very excited to see his presentation today, and I'm sure that we're going to have very fruitful discussion at the end. Don't want to take more time. Puriya John, خوش آمدید. Stage is yours.
Thank you very much. Thanks for your invitation. That's an honor to be on the ACNS panel. Special thanks to my school time friend, Mohsen, who we have had many excellent experiences, including the year I was working with him at the Jamaica Hospital. I was actually with passion of training that I thought of creating those videos. Okay, so jumping on the subject, basics of neuroangiography in 40 minutes. So obviously I have to be selective of what we're talking about. I would have starting fellows and junior fellows in mind when creating these slides and talking about them. And remembering my time as a fellow at Mount Sinai. I think when talking about basics of neuroangiography, we have to appreciate that the trainees in neurointervention or neuroangiography aren't homogeneous. They come from different backgrounds. Some are neurologists, some are neurosurgeons, some neuroradiologists. So everyone brings strength points and things that they don't know, and often the other counterparts know. So the greatest programs are the ones that they have attendings from all three backgrounds. In my understanding, so neuroradiologists are the ones that started the field. So they have very good understanding of radiographic anatomy and using the devices, including the angiographic machine, but they may be lacking understanding of clinical correlations, as they always write at the bottom of their reports, and the significance of patients' clinics in choosing the cases or including them. Neurosurgeons obviously are great in understanding the three-dimensional anatomy, and they have a background in recruiting and consenting patients for procedures, understanding what the procedure risk is, so they don't panic when they see that a patient is having a new focal deficit at the conclusion of procedure. They know how to consent the patients for that cause, but they also would need more understanding of what the machines are. And although they have dexterities in the open surgery, there are different maneuvers that they need to know in neuroangiography. So with that background, we'll start talking about basic concepts. And to me, understanding basic concepts about neuroangiography are three things. One is knowing the indications. So why we do angiography, why we do diagnostic angiogram, and why we don't choose other modalities for that. The basic concept is about knowing our tools, and tools are both the machines, the non-consumables, the great angiographic biplane machine we have with all the intricate post-processing tools we have, And also knowing our catheters, why we name them, how we name them, what are the differences, and what different shapes mean for different anatomy. How we can best choose a catheter for a particular patient, knowing his anatomy or her anatomy. So, and last but not the least, are procedural risk and how to mitigate them. I can promise you, everyone you talk to, when he was a fellow, he has that bitter experience of admitting a patient for a outpatient angiogram and then having to admit him after he had a stroke under his or her hand. And this is really traumatizing, especially if you're from a non-procedural background like radiologists or neurologists. You basically don't know what to do. You lose your confidence. So knowing the basic concepts are also about knowing what risk you impose to the patient and how to mitigate them, and how to honestly talk to the patient after knowing that you're doing best to reduce the risk, and also informing him what the risk may persist. So why we do angiogram? So there are two things that I understand, and that is angiogram has superior, let me get to this laser pointer. Everyone can see my laser pointer?
Yes.
Yes,
Great.
yes.
So it has has a superior resolution, spatial resolution, and that is basically an X-ray tube which then crosses the head or neck, and then the shadows of the contrast, or everything radio opaque, will be projected on an image intensifier. The great thing about this device is that in addition to digital zoom, which all the imaging tools it has also has optical zoom, which then with aid of changing the exposure and other parameters can give you a superior spatial resolution. You can not only see MCAs and branches, but you can also see the fine penetrating arteries, and you can plan your experiment based on that. The other aspect of angiogram is that it gives you a time resolved image. So let me show you. Every angiogram has this is an angiogram, okay? This is an injection of the left internal carotid in a patient who has venous stenosis. So it gives you, every angiogram comes in three phases. Starts with arterial phase, and that is this bit, so you can see the arteries very well, and not the other vascular structures. And then when it further gets to the end artery, you see a smear of contrast spreading, and that's what we call a capillary phase. And then at the end of capillary phase, you start seeing the veins, both deep and superficial, and that is the venous phase. So this time resolved imaging will not only allow you to see the structures better, because at one time you can see the arteries and not the capillaries or arterioles and the veins, and then at the other time you can see the veins and not the other two. So it will improve your resolution, but also give you ability to appreciate the dynamic nature of the cerebral perfusion. So it will allow you to see the shunt diseases and the structures that are the pathologies that are essentially affecting the dynamism. So let's talk about the tools. The angiographic machine and the catheters are our tools. So I don't want to get to every details of the angiographic machine, but the one thing, I mean, this is a beautiful sample, an old Siemens one, and you see a nice control panel. So in angiograms, they are usually a radiologist with you. Sometimes there is a scrub radiologist. Sometimes radiologists sit outside. I always encourage the trainees from any background, radiology or not, to learn and understand the operation of machines. The things I want to mention here are these two control panels. Above is from Siemens, below from Philips, and then the use of so you will get superior imaging. I mean, we both, me and Mohsen, had a radiologists as our mentors, and they always emphasize on the how important it is to improve the quality of imaging, getting excellent quality, because then diagnosis is the mother of treatment. So to see more means you're more enabled to treat and avoid complications. So part of things that are often, I mean, everyone knows how to move machine and how to move the arms in different directions, but the things that are I see not infrequently neglected and not learned are using the collimators, and that is closing off the field and using the, let me see the laser pointer, yes. So this is a collimator in Philips and Siemens, and using the filters. So I will show you an examples on both. So invisible. Okay, so this is a view, a fluoroscopy on preparation of the views that you see the filters coming from the sides, and that is very important, especially if you're looking at the structures that are outside the skull in the soft tissue, or you happen to have part of the skull removed. So the way these machines work are they get an average of the amount of impedances, if you want to call them, in front of X-ray, and so they will adjust the exposure. So usually the exposure they provide, it will lead to the burnout of the structures. The structures will be outside in the white, in the soft tissue would be overexposed, so you won't see them very well. But if you bring along the filters, you are adjusting for that effect. You see those soft tissues you can see on the sides, and then collimators come in and close off this way, will not only improve the collimation, which is prerequisite for decreased diffractions, but also will decrease the exposure to yourself and the patient. And this way you can get better quality, especially on the ECA runs. So understanding the machine is also understanding what software abilities it has. So it can do regular angiogram, it can do a roadmap, meaning that it would get like a negative representation of the artery. It can make a roadmap out of a DSA, and that's important if, for example, you want to have a venous roadmap. So you would set the DSA on the frame that shows the veins in the venous face, and then you make a roadmap out of it. And you can actually, the new devices, they can make a 3D roadmap. So they would make a 3D and then on a special angle, they allow you to navigate in a 3D representation. There are all other devices, abilities like 3D DSA, which I will show you, and then the rotational dyna scan. So a lot of time, we've done it with Mohsen a lot, that you do your procedure, you're worried about perforation, so you want to see if there is a lot of bleeding, or the patient is brought in, and then you see you want to acute a stroke patient, so you want to see if there's any hemorrhage before doing the procedure. It basically is a low resolution scan that you can do, and then you can actually inject a lower concentration of contrast, so you get a vaso CT, and I show you examples. So this one is a rotational DSA, 3D DSA of a infratentorial AVM, and then you can then turn this, not exactly this patient, but this type of DSA into rotational 3D representation, which you can use both for surgical, open surgical planning, and also understanding anatomy for endovascular treatment. And then there are all different kind of graphics you can work with. This is a special graphics that will allow you to see through the vessels and see the branches. So, and then the vaso-CT we talked about, you can actually see very well the relation of the instruments you have deployed. In this case, a flow diverting stent to the pathology. So by having a diluted contrast, you can actually distinguish between the stent, which is very radial opaque, and then see the vessels and the associated pathology, in this case an aneurysm. And here you see how well your flow diverting stent is covering the neck. This is one of the cases we did with Mohsen. So knowing how, not only how to operate machine inside, but also how to post-process the images you get is very, very important. Enables you to not only create gorgeous videos for presentations like this, but also make you enable to see the with a attack plan, and then check outcome of your treatment. Even when you're partially deploying a stent and you want to see if you have good to continue or you have to take it away. So understanding the tools, basic concepts, we talk about the indications, we talk about tools as a machine, but also there are some consumables. So, you know, when I was a resident, I was fermenting my interest in neuroangiography. I want to understand what different, like what is a, so I used to get a lot of names, and then I realized that those names are just brand names, and there are different types of tools. So it's better to focus on types of tools and talking about some basic definitions. So sheaths, for example, is obviously a tubular hollow tube that crosses the skin to artery. For that reason, you need a dilator, and you can, yes, you can see the dilator here. So that is to basically dissect the soft tissue under the skin. And they're named by the inner diameter in French size. So there are generally two types of sheaths. There are femoral sheaths, which are regular. They have more thicker thickness. They have bigger thickness. And then you have a slender sheath because they use for radials. And they are, because they're less soft tissue, so they have been able to make them thinner. The regular femoral sheaths, they come in one French number. We usually have seen from 4 to 9. Slender sheaths usually come in two, like pairs of numbers. And the 4/5 means that the inner diameter is 5, but the outer diameter is equal to a regular 4 French, and that is because they have a thinner wall, and that's how it goes on for 3 different sizes. And it also helps because you get when you're assembling your triaxial system, you get some sizes in French and some sizes in thousandths of inches. And so knowing how to convert them is helpful. A while ago, I calculated one French was about 13 thousandths of inches. I hope it stays the same at the present time. So, and then talking about catheters. So the catheters, they also come in different categories. One is diagnostic angiographic catheter. That's what you do your diagnostic angiogram. There are many different types. We're not talking about the spinal. angiogram, but just for cerebral angiogram, there are angle taper or vert. There's also Bernstein, which is a brand of catheter. I think the angulation is very similar to vert, if not exactly the same. And then you have Siemens 2. And the way we choose between Siemens 2 or vert are based on arch anatomy. So we learn about type 1, which is the easiest origin of all the cerebral vessels on the arch are almost in one plane, and then you get type 2 and type 3, and gradually because of the age and the hypertension, the origin of more proximal arteries descend towards the ascending aorta. So that makes use of a Siemens 2 catheter almost ideal, because Siemens 2 catheter is how the proximal and distal curves are very much similar, crafted like a type 3 arch vessel origin, especially when the vessels are going towards left. And using an angle catheter will make you think of all the bad things you've done in your life. It will not advance. You advance the catheter in type 3 arches instead of going up the, for example, subclavian. It will jump out. If you want to go up to the left common, it will again jump out. So it makes it very difficult to use an angle. So looking at the CT angiogram before doing your diagnostic cerebral angiogram is very important in the sense of choosing the right catheter. And remember, if you let's say do less of catheter maneuvering, then the risk of procedural complication and stroke dramatically drops. And one word about Siemens 2 catheter is how to shape them. So unlike the angled catheter, Siemens 2 has to be shaped. And that is because the initial shape is not ready. So you advance on a femoral angiogram, you advance the catheter over a wire, and to the origin, to the ascending aorta, you would draw the wire in, and you start twisting the catheter until you see an alpha shape. And you pull down the catheter so that the distal alpha shape becomes horizontal. And then you insert relatively quickly the wire, and then you get to the right shape. There are different ways of shaping. Some of them are a little dangerous, because then you have to go into subclavian artery or even bounce back on the aortic valve or the left ventricle, which can be causing problems. So this one is the safest way of shaping the Siemens 2 catheter. And talking about other types of catheters. So this is mostly when we are speaking about interventions because how tortuous vessels are. So you have to have flexible catheters. On the other hand, your flexible catheters will not be following the forward force you are exerting. Remember, you only can increase the force or decrease the force, pull back or push forward the catheter. So when they are flexible enough to being able to go to different tortuosities, then they also will become too flimsy and they will not be following you. So the way people have found to get the best of both worlds is develop a triaxial system. So you would go in you would basically have a larger outer catheter, shorter and stronger catheter, and you name them guide catheter. And then you would have the longest, thinnest, most flexible catheter, and that is your microcatheter. And then you will have a intermediate one. It's called intermediate catheter, or some companies, they call it distal access catheter. And this way, you not only able to go through different vasculatures, but the support which you need to translate your forward force into your desired movement will be gained by having a slightly stronger, less flexible catheter more proximally. So these are different kinds of catheters, and that was very helpful when I started understanding. So your guide catheter, some of the guides are sheaths as well, so you don't have a separate sheath. You can cross the skin and get to your artery with a guide catheter. And selection catheter we'll talk about in a bit, and then your intermediate catheter, your micro catheter. I haven't seen a clear definition of the sizes, but usually anything below 35 thousandths of inches is called microcatheter. Anything above, let's say, 72 thousandths of inches is called a guide catheter, and intermediate catheter is between, but there is no solid definition on that. And then you have your wires. So let's see an example of how your triaxial system enables you to go through a complex, a very tortuous vasculature. So let me first introduce. So this is tip of intermediate catheter. The guide catheter, you even don't see it. It's under in the cervical. This is a lateral view of a stroke case where you see your internal carotid, your ophthalmic, and then distal into the MCA. There is a like M3 branch occlusion. We're trying to get into that. So your guide catheter is even not in the scene. Your intermediate catheter is here, your microcatheter, and this is the wire. And just look at how they will go in sequence. The wire will go up, and enjoy the music. And the wire will go up, and then that will be followed by microcatheter, and then your intermediate catheter will follow, and then provides enough support for wire to then be more following better your directions, and then your wire is able to get to the right vessel. So you see, you're gradually improving the support, but also allowing your thinnest structure, which is the microcatheter, to get into the finest vessels without causing damage. Okay, so selection catheter, I promised to talk about. In old ages, the guide catheters used to be less flexible and they were angled. The newer generation of guide catheters are more flexible. They're not angled, so they cannot select vessels in the arch. So what they do is they would have a selection catheter, which is about 20 to 30 centimeters longer than your guide catheter. You basically put it through the guide catheter and select the vessel, and then with the wire and selection catheter, you go up enough so that you provide enough support for your guide catheter, and then you advance your guide catheter in the vessel of choice, like internal carotid or vert, and then you pull out your selection catheter and guide wire, and this way your guide catheter will be at the vessel of your choice, and the selection catheter or type of catheter that will help you to do that selection while having a non-selecting, very soft and flexible end guide catheter, so that you can advance your guide catheter as much as you want. So I also want to share this. This is a snapshot of a Excel file I created. So you see different companies at the top, at the columns, and then different types of catheters. So this way I kind of got myself out of confusion of various names. What is a selection catheter? What is a reperfusion catheter or aspiration catheter? What are different names that different companies create? So when I'm doing procedure, if I don't have SOFIA, for example, by microvention, then I will be asking for ACE. I will not ask for SL10, for example, which is a different type of catheter. And this is a QR code. If you guys want to access the whole Excel file on my drive, there should not be any problem in accessing it. If so, email me. And it's few years outdated, but I don't think there's so many new products that are on the market. Okay, so talking about the risks. So you can, again, that nightmare, admitting a patient for an outpatient angiogram and then turning a patient into a stroke patient is something everyone wants to avoid. So it's helpful to know what causes a stroke. It's usually either air or blood clot. People think of later more than former. But there are three sources I can imagine. One of them is the thromboembolic sources, which is about catheter maneuvering, how well you're able to move your catheter and watch it when it gets into a plaque and not be violently pulling it out of the plaque so that it flickers pieces off and causing a stroke. But the two other sources, the air and the clots from stagnant blood in the catheter, are the things that could be subject of our talk today. The reason is that there are certain concepts that if it settles in our mind, it will actually improve our procedural safety and make it safer for people. So the air, it can be in the syringe. So for like part of my junior, I only was learning how well I should fill the syringes without a lot of air, and how to find them and how to make it less air. So avoiding air in the syringe, and also when you have the wire in the catheter, the air tends to get trapped between those two when you pull the wire out. If you don't do what we'll show you, then you are at the risk of injecting and pushing this air into the cerebral vasculature and cause bad things, namely stroke. The clots, remember that you are dealing with a arterial pressure system. So your the artery, the pressured blood will be pushing to come into the catheter. So it will gradually advance if there is no counter pressure. That's why we'll be talking about different systems of the angiograms. Let me see how much time I have. How much time I have?
We have around 10 minutes.
10 minutes. Okay, I'll try to be quick. So, and so what we should do, double flush, double flush, double flush. So there are two systems, and that's how you set up your diagnostic angiogram. The open system is meaning that your catheter is directly connected to the syringe, and the closed system means that you have a pressured bag, not this one, a pressured bag, and that is having the fluid with the pressure into the catheter, and then through a Y adapter you have your micro wire in it. So one thing, and that's part of the educational videos, we talk about the double flushing, which I will show you here, is what will help you not cause a stroke. So this is a catheter here, and this is a wire pulling the wire out. You're trying to fill the hub. You see the bubbles coming out? See, so these are the bubbles that trapped between the catheter and the wire. And you flicker, do the first flush, which is a backward flush, and pull all the stagnant blood, which could cause the stroke, they cause the clot out, and then change the syringe and put in a second one. This one, do the forward flushing, and then clean all the, fill all the syringe with heparinized saline, and then connecting the contrast syringe. and always do a little bit of pull. The other thing we should be in an open system, you always have to have your hand vertical with the syringe up to avoid any air getting into the catheter. And you always do a little pushes on the plunger when you're adjusting the views, not just laying the plunger on the bed. And then for open systems, you do the double flushing. The backward flush is actually done by the pressure of blood. So you open it and flicker, let the blood come out and bring all the clots. And then you only do the forward flushing by connecting the syringe with heparinized saline. Open the stopcock, open the wide adapter, first clearing on a 3-step way, and then pushing, and then again clearing the whatever is between the stopcock. And this way, cleaning all the air and clots that could be, and believe me, there are several times I actually pulled out clots that I would otherwise have pushed and caused stroke. So quickly talking about angiographic views, as much as I have time. In the angiographic views are mainly depending on what artery you inject. So for internal carotid artery and vertebral artery, there are usually two pairs. One is a straight and or standard. The other pair on both AP and lateral are oblique, and also similarly for vertebral artery injection. So for internal carotid artery injection, one note is that distal the internal carotid is, in order to get it out of the shadow of the bone, meaning the frontal table and also the petrosal bone, you have to come out with a view called a Townes view. And this way you best see the proximal ACA and MCA off of the bone shadow. To do that, this should be your X-ray direction. To get that X-ray direction, you basically have to superimpose the upper orbital ridge on the ridge of petrosal bone. And so then the second view is what we call transorbital view, and that is to open up certain things. So let me show you on this videos created by Mohsen. Basically, what it does is you will bring the orbital foramen into the middle of the orbit, and this way. So this is done by basically moving the for the right side injections caudal and onto the right. And so this is your orbital foramen. This is the orbit, is in the center. And to make a comparison as what it would mean is, so this is your cerebral angiogram on how the transorbital will look like, and this is the subtracted view. And if you put them next to each other, so this is Townes view, and this is transorbital. So you would see that first this carotid siphon has kind of untwisted and opened up, so that you in transorbital, so you can see the pathologies here more. The other benefit is in ACOM complex, it's distal A1 and ACOM and A2. See how well it has opened up. You can actually see the ACOM on the transorbital. Otherwise, you couldn't see it in Townes view. And also the angle of the MCA bifurcation here is quite close, and this here has opened up. And it depends a little bit on the anatomy of the patient, but in general that is helpful. So and then speaking of the oblique lateral view, basically what you do here is so the straight lateral is good for distal ACMCA branches, but as you can see, the ICA bifurcation, which is here, and proximal ICA and ACA and MCA kind of superimpose on the lateral. So you want to separate them, and the way you do it is by for right side injection, you basically bring your side of the B plane towards feet and up. And this way you get the shadow of ACA and MCA off of each other. And this way you get a better view. So this is the angiographic view. And if you want to compare them side by side, so this is straight lateral view. You see ACA, MCA are superimposed here. On the oblique view, you see the A1 segments separated from M1 segment, and then you see the MCA bifurcation very well. And that's what the oblique lateral will give you. And then for the vertebrobasilar angiogram, so that is oblique views. Angiogram. So it is starting with understanding that the basilar artery gets an angulation, a caudal angulation. So you have to adjust your X-ray direction accordingly to be able to see the basilar artery and its branches. And to do so, you get something called transfacial view, which meaning that the petrosal ridge should be somewhere in the middle of the orbit. Remember, for Townes view, it was up here. So it will help you to get better visualization. And so this would be the result of your angiogram. So here you can see the verts and the basilar artery and the ICA, SCA, proximal PCA very well, but not very good for the distal PCA branches. If you want to get very well on the distal PCA branches, then you have to get to a view called hypertown, and that is basically adjusting the X-ray perpendicular to the PCAs, and this way you would not see much of the basilar artery, but your PCA, P2, P3s will open up very beautifully, and that is done by making the A plane very, very cranial. It's more than you do. It's called transforaminal because you see you kind of perpendicular to the foramen magnum as well. So it gives you a very nice map out of this second branch of PCA, as you can see here. You see the basilar artery kind of crunched together. But the other benefit of this is when you want to do procedures on the venous sinuses. So the complex shape of transverse and sigmoid are opened up in that view. And this gives you excellent maneuverability. So trying to wrap up, there are two sources I want to share with you. One of them is the famous neuroangio.org by people of NYU. It's very great, comprehensive. You can almost find everything. It's more like a big textbook mapped out on a website. And then so Dr. Nouri talked about my YouTube channel. So this on the left, the QR code is for channel itself, and then a channel has several playlists, including several lectures by Alejandro Bernstein, René Chapeau, but also a playlist of NIR for beginners, which is kind of compilation of what we talked about today. So thank you very much for your time, and hopefully that was helpful.
Thank you so informative and great to refresh our mind again about the basics of angiogram. I know that this presentation was prepared mainly for beginners, for fellows, and some extent even for like at some points even for experienced neuro interventionists. I mean, I wish that we had more time to discuss more details about the views. We all know that it cannot be emphasized enough how important they are, because 3D angiograms and 3D roadmaps are not available to everybody. So knowing details of how to get the appropriate view on an angiogram, for example, of an aneurysm or an occluded branch, is crucial for a neurointerventionist by knowing how to move the A plane or B plane to get the appropriate view and make the appropriate angles. I definitely recommend whoever is interested to go to Dr. Moshadi's atlas, online atlas, and learn more details about how creating these views. Some other things that we discussed here were about safety, like how preparing syringes, lines, everything. Again, you could find more details in the online atlas. The thing is, it's not. It's very, very crucial, very important. Sometimes just like dismiss how important they are. But just to mention that in our training, both me and Dr. Moshadi went through. For example, for the first couple of months when we were scrubbing with Dr. Bernstein, we weren't even allowed to touch syringes. We were just watching there. Technically, the best fellow was the one who was doing less, because this may seem like something very simple and rudimentary, but it's really, really important. Even sometimes simple like preparation of a syringe could cause problems. In your experience, Puriyajan, now that you are training also fellows and you had seen like some other fellows during your own training, if you want to tell us like the main 2 or 3 factors usually missed by junior fellows, and you want like to improve them in their skills to prevent like mishaps in their angiograms, what are those factors if you want to review for us?
So I would say that preparing the catheters before putting them through the sheath, making sure there are no bubbles, and having a two-way stopcock. This is number 1. Number 2 is the importance of preparing the syringes. A lot of time, small bubbles are there. Sometimes they're not completely emptied of the blood in the preceding run. And the third one, I would say the double flushes, how to do them and how to do them well.
One other thing that I want to add here is as well that, some people, especially when they start, and again, especially from neurosurgery background, because many people going to angiosurgery think that, oh, that's easy job compared with what we do as open surgeons, and what we do there is more like meticulous. But navigating a catheter is not like just doing a computer game. It's not just by forcing something into the vessels to go. Sometimes you need to learn, not sometimes, always, you need to learn how your catheter would react and to your manual, to your manipulations, like when you're rotating, when you're increasing the force, when you're reducing the tension. These are very, very important, and I've seen many occasions, not just by myself, by like other colleagues or working with other fellows, that when someone is expecting a catheter to go forward, it jumps back, you lose access, or vice versa. You expect that to come back, it just jumps forwards and ruptures a vessel or an aneurysm. So understanding how these catheters are working, the catheter is very, very important. That should not be missed for the beginners. Is there anything else that you wanna add, Puriyajan?
There are many details and maneuvering tips, but they are like they require whole different lectures. We try to compile some of the videos of how to do the radial angiogram, how to select vessels from a femoral. So I would refer the interested people to that. But what I would say is definitely the neuroendovascular field is, as you say, it looks very simple, but it has two different edges. One is it can very simple because you're in the CNS vasculature, and CNS is not forgiving for the small hits and strokes. So you see very bad complications, and the bad complications, the worst complications are the ones you don't know how you have caused them. So you don't know how to avoid them, and trying to understand the steps is very important. The other aspect is of the great things you can do with neuroendovascular field. It is expanding. As you know, there are more trials and devices that are showing that endovascular treatments are becoming more and more safer and effective. Obviously, I mean, you're a neurosurgeon, and everyone else here on this panel know that how difficult is accessing. But here, the vessels as hollow tubes provide you with a natural. So all in all, it makes it very exciting field.
Thank you so much, Purino, for joining us today. I think many thanks, Ben and Dr. Raja, for having us here. I think finish the conversation here by adding that again for young neurointerventionists and fellows especially, how important it is to learn about the basics before thinking about advanced techniques in intervention. Thank you so much, everybody, for joining us today.
Can I ask a quick question to Dr. Hussain? Yeah, and congratulations and thank you for your education material. Just subscribe to the channel as well. I have two questions to ask for young users. I would like to first is about the closure, the femoral closure techniques. So there are different types of closure techniques or device. What would you advise to prevent the complication, like pseudoaneurysm or dissection to the neuronemes? My second question is about for beginning for the aneurysm cases. I think one of the difficulty would be ACM aneurysms. So how I saw you have some sharing of your experience on how to adjusting the wheels. So how any tips to the beginners how can they expose an optimal wheel for the ACM aneurysms for embolization? Yes, thank you.
You mean, sorry, exposing the optimal what aspect?
Views. Yeah, optimal views.
Views. Okay, I see. So in terms of access, I would say that the access complications are more of about using the closure device are caused by the time of access. So excelling the technique for accessing to make it less complicated. Make sure the wire that goes in isn't facing any resistance, and if it does, how to safely maneuver and get it out or abort and try to access again. Overall, the way you access is more important in reducing the complications than using the closure device. Closure device, especially my 1 year of experience in Iran. I mean, in the US, we had the luxury of using any closure device we wanted. So there I was using Vascade, which is less invasive for anything 5 or 6 French. And then if I use higher Frenches or with 6 French, we use a lot of heparin, then we would use more like robust closure devices like Perclose and Angiosil. But when I moved here in Iran, we always have one closure device for every access, and that is sandbags. So and believe me, they work well. And so it brings me to thinking that the closure device is more of a convenience to the patients than improving the eventual outcome, because it would allow the patient mobility more. Again, I think if you have closure device at your disposal, using them is helpful in reducing the patient burden. But if you don't have a simple compression, probably works as well, especially if you wait enough for your heparin to wean off. In terms of the views, so I mean, I would also invite Dr. Nouri as more experience in commenting on that. But in general, so it depends on which way the aneurysm is looking. If the aneurysm is looking more caudally than cranially, then you would start with positioning your head flexed or extended to make the viewing easier. In general, if you are coiling, you want to have a view where you see the neck, because you want to make sure everything above the neck is covered and no coil is hanging below the neck in the parent artery. So something that separates the artery, the parent artery, from the aneurysm is crucial. So you choose your views such. And I mean, you can come up with recommendations, but the ACOM complex is really so complex that you have to look at your own cases. But if you want to use a stent or a stent assisted or flow diverters, obviously your landing zones of your stent become more crucial. So you can have a neck on one view and optimize, and then your landing zone in the other view if you're using a biplane.
I have a question. Thank you very much, Dr. Mushadi, for the nice presentation, and Dr. Nouri. From an open cerebrovascular point of view, I would like to take the opportunity to ask you both if you can describe to us from an interventionalist aspects the practice or the care for AVMs, non-ruptured AVMs that you face and that patients present like with seizures or headaches, or incidentally discovered. What do you do for management for these patients? Do you embolize? Do you follow up? Do you embolize followed by surgery? It would be really, really interesting to get both of your perspectives on the current management of these AVMs that we find. Thank you.
Oh, sure. Especially for those that are like non-ruptured AVMs. Usually we discuss them in panels, including a couple of like open vascular, endovascular, and radiosurgeons, to make appropriate plan for a patient with an AVM. If it's grade 3 or above, even if symptomatic, we usually do not plan anything for them. Again, for grade 1 and 2, we talk about grade 1, but grade 1 could be like again be a spectrum. It's not like a single case. So if you find it like surgically accessible, endovascularly safe, or if the symptoms are like progressive, or we feel that it's not like it's resistant to like other treatments, and also age is an important factor here. It's very, very important to know how old the patient is. And so these are the factors usually we take into account before making any recommendations. And if you look at like other institutes as well, you see that most centers go by the experience they had. Like some centers, they still treat even non-ruptured, even grade 3 patients. You could see those publications even from the US. But in some other centers, you see that they're not touching any grade 1 or 2 that is not bled. It's something that, as I said again, it depends very much on the experience of your center and how comfortable you guys think that you would be in treating those low-grade AVMs. And about the other question about, I just want to make like a short comment about the ACOM question that we discussed earlier. As Dr. Moshedi very well mentioned, the views that you make an angiogram, they have many details. They're like something generally applicable to all the aneurysms, like how to have like the appropriate branch for stenting, or how to have the whole aneurysm like above a certain line, not to avoid like coil prolapse into the parent vessels. But again, each aneurysm has its own like details about making views. For ACOM, the projection of the aneurysm is very important. And also the A1, A2 fork. As open neurosurgeons, also we know that that fork between the A1 and A2 is technically talking about the relations of the bilateral A2s on the coronal plane. If an A2, like ipsilateral A2 is posterior to the contralateral, that fork is called open fork, which means that you have an open angle and you can attack the aneurysm better. That's usually suitable for all the aneurysms except for posterior looking ACOM aneurysms. I'm talking about open surgery now. Almost the same thing applies to endovascular. When you have an open fork from the right side, usually you bring your A-plane camera toward the right. And again, for most aneurysms, except for those posterior looking, usually you bring the A-plane caudal. So this way you're going to separate dome of the aneurysm from the neck of the aneurysm. But for those aneurysms that are posteriorly looking, you usually bring your A-plane camera to cranial side. So again, you could separate the dome from the neck of the aneurysm. About going right or left, I explained. Usually we go with the side that the fork of A2 is open.
Yes, thank you so much. It's
Yeah,
good.
and addressing the question about unruptured AVM, yeah, I totally agree with Dr. Nouri. This is our experience. I mean, mine was more limited than Dr. Nouri, but is that treating AVMs is really even when you finish the procedure, because you're dealing with a complex hemodynamic situation that you have acutely altered, you can't predict, or you can't predict 100% of how the things will go. Unlike aneurysm, when you close off the aneurysm, you have closed off aneurysms. This is not any complexity there. But AVM is a very complex. You slow down the flow. You don't know what would happen to the venous side. The complex hemodynamics of nidus, getting blood from several feeders. So decision about treating AVM is unruptured AVM is complex. But one thing that could happen, and there have been data showing that if you do an angiogram and see two pathologies, and treating either of them is going to reduce chances of bleeding. And one is an aneurysm, either prenidal aneurysm or intranidal aneurysm. So you're not getting into that complex alteration of AVM hemodynamics if you close off a sidewall flow-related aneurysm on the nidus or before that. The other pathology you can find in your diagnostic angiogram and treat it are AV fistulas that sometimes form on the aneurysm nidus, and they have been shown to increase the venous pressure, and that increases the chances of hemorrhage. And again, those are relatively low risk procedures to do than actually attacking the AVM itself and getting into the nidus.
Perfect, thank you.
So if there's no further questions, then maybe shall I invite our second chair of today, Professor Tariq, and to introduce our second speaker and chair the second section. Thank you so much.
Thank you so much for inviting me for this very interesting session. Thank you for the previous speakers for the very interesting presentation and discussion. And without further ado, I would like to ask Dr. Quan Kai to present his presentation about comprehensive management of skull-base tumors and one-stop reconstruction of the skull base. And I just want to say I really like the title of the presentation, because doing skull-base surgery goes hand in hand, with knowing how to reconstruct the skull base as well. They can't be done, in separation. They have to go hand in hand. So please, Dr. Quan, go ahead.
Okay, thank you. Let me share our PowerPoint. Good morning, good afternoon, and good evening, distinguished professor and college. It's a great honor to present scan-based MDT from Huashan Hospital and introduce our comprehensive management strategy for scan-based tumor. Our discussion will include analysis of epidemiological trend and detailed evaluate surgical intervention and the review of our experience in reconstruction scan-based defector. Now let's start the lecture. Also, scan-based tumor are rare. The majority of the type present aggressive biology behaviors. The annual incidence of lateral scan-based tumor range from 0.8 to 6 per million, and primarily affect the temporal and sphenoid bone. Squamous cell carcinoma is predominant, accounting for over 40% of all cases, followed by cellular cell carcinoma, adenocystic carcinoma, malignant meningioma, and melanoma. Our MDT has encountered a range of pathology type, each presents a unique therapeutic challenge. And then the characteristic of the tumor is their spreading around the nerves. In case of the malignant tumor of maxillary sinus, this manifests as spreading along the we can see the infraorbital or the palatine nerves and reach the sphenoid, palatine, and foramen ovale. It usually eventually breaks through the foramen ovale to the ganglia ganglion and the dura mater. And of course, some meningioma and schwannoma can also spread the extracranial through the natural features of the temporal and sphenoid bone. So this part of the sprint is creation for devising effective treatment plan. Go to the propertive evaluation. We think the high resolution scan are very important in the propertive assessment. It can help evaluate the tumor size, erosion of the external ordinary canal, involvement of the middle ear and mastoid. Additionally, they can depict the extent of the tumor explained to some key instructions such as the jugular bulb, the ICA, and aiding in disease staging. In MR, tumor originates from the area such as parotoid gland, maxillary sinus, pharyngeal, and the orbital can present some abnormal soft tissue signals such as small thickening of the viscera, conceal expand of the foramen ovale, and the lateral buckling of the cavernous sinus dura. So we think in some selecting patients, the angiogram and the BOT can require to assess the involvement of the ipsilateral ICA. It's if it is deemed that the tumor cannot resect without sacrifice the ICA, we should perform a temporary BOT. And if the BOT was negative, sometime we use embolization with coil carry out before 2 weeks pre-operative. In addition to surgical resection, the focus of our work is on the defector reconstruction. The goal is to create a barrier between the intracranial and the external environment. It can prevent some complication such as CSF leakage and post-operative infection. It can also restore facial form and function. The choice of the flap depends on the size of the defectors and the patient's comorbidities and the require tissue characteristic. Usually, we recommend the use of anterior lateral side frame flap to rebuilding some large size defector. And then the scan-based defector can usually divide into three range. Range 1 usually include the forehand, eyelid, nasal skin, and the tumor surrounds the orbital nasal cavity and sinus. Sometimes limited midline resection can be a restriction by the pedicle ganglion, and the large defector or some this with the compromise the vascular supply during previous surgery can require a frame flap, such as ALT flap. If the operation to resect the aggressive cancer resection in the lateral range 1, it may involve the orbital resection or the maxillectomy. We usually use temporalized flap or frame flap to recover the orbital cavity. And the range 2 defector usually extends from the pitcher's temporal bone to the posterior orbital wall. The most common size includes the infratemporal fossa and triangle plantar fossa. It's typically the flap were usually to prevent some complication such as CSF leakage, and it can restore facial form and function. The choice of the flap depends on the size of the defectors and the patient's mobility and the required tissue characteristic. And we usually recommend the using of the anterior lateral side flap to repair some large size defector. And then the scan-based defector can usually divide into three range. Range 1 usually includes the forehand, eyelid, and the nasal skin, and the tumor surrounds the orbital nasal cavity and the sinus. Sometimes limited midline resection can be a reconstruction with pedicle ganglion, and sometimes the larger defector or this can this with the combined with the vascular supply due to the previous surgery may require a free flap, such as the ALT flap. And then if the tumor involves the eye bone or orbital, we need to perform the orbital externalization or the maxillectomy. We usually use the temporalized flap or free flap to cover the residue of the orbital cavity. And the region 2 defectors usually extend from the pitcher's temporal bone to the posterior orbital wall. And the most common sites include the infratemporal fossa and the triangle plantar fossas. They typically require the microtaneous flap, such as the ALT flap, and may necessarily include some muscle and fat tissue to maintain the facial content and provide the adequate scan-based supply. And the defects in the range 3 are usually associated with the tumor of ear, peptide gland, scape, or the temporal bone. And the most common involves scan tumor of the external auditory canal. The median size defector can be reconstructed by the with temporalized muscle flap, while the large defector we can use muscle or mycocutaneous flap. So this is a summary of our restoration strategy. We have combined the pedicle and frame flap technique, leverage the advantage of each to achieve the best outcome. So our cohort include two cases of the scum-based malignancy involving dural or brain. The vast majority of which are the gravest tumor involved multiply scum-based range, presents a challenge to design an approach and one-stage restructuring stage. And we can show some major cases. This is the first major patient, 57-year-old female, and she with 2 months history of left temporal mass. The patient underwent resection for squamous cell carcinoma at local hospital 7 years ago, and she received the subsequent radiotherapy and chemotherapy. The CT reveals the tumor main body located in the triangle parietal fossa, with destruction of the bone of the sphenoid, maxillary, and pharyngeal process, and there was suspected cervic lymph node metastasis. In MR, shows the tumor involved of the temporal muscle, cavernous sinus, and dura mater, presents the heterogeneous enhanced in contrast T1 image. So before the proceeding, it is necessary to review the modified Pittsburgh stage system, as well as the clinical framework for classifying the survey of lateral scum-based tumor and guiding the extent of the resection. We think it's very important because depending on the extent of the tumor involvement, the degree of the temporal bone resection is determined. Usually, the majority of malignants require en bloc resection with a 1.5 centimeter expanded margin, and the extent of the temporal bone resection greatly affects whether the margin is negative. Usually, the tumor in stage T4 often requires a total temporal bone resection. So go back to this patient. This patient is radiologically staging at grade 4, so we perform an expanding arterial incision. We en bloc resect the tumor involved the left mandible, involved the diaphragmatic arc, lateral parts of the temporal bone, and involved the external auditory canal and internal ear, and involved the dural. We also perform a neck dissection. After resection of the tumor, there was scum-based defector in range 2 and range 3. In this case, we use an ALT flap for restriction. Anastomosis to the fissure artery and external jugular vein, and filling the tumor cavity with fat and muscle tissue beneath the flap. And then this is the post-operative CT scan and the patient's appearance. It shows a significant improvement. However, the tumor recurrence in the orbital range after 5 months remind us of the complex we face. And this is the second major patient. Is a young patient. He had radiotherapy for nasal pharyngeal carcinoma 9 years ago and presents a new scum-based lesion. manifesting as this patient manifested as facial paralysis and external ordinary corneal mass with bleeding, and by biopsy confirmed Austin carcinomas at local hospital. The property CT scan review temporal bone mass involves the external ordinary corneal, tympanic cavity, diameter, and cerebellum, with destruction of the right side optic bone and the temporal bone. And there was suspected thoracic lymph node metastasis. The MR further declares the extent of the involvement with the tumors anterior and inferior both near the IC and the vertebral artery. We also perform a three-dimension resection, visualizing the relationship between the tumor and the vertebral artery. So this patient is radiologically staging as stage 4. We perform extending anterior excision and resect the tumor, exterior ordinary cornea, lateral temporal bone, external ear, and involved dural. And a neck dissection was also performed. The scan-based diffractor was using ALT free flap to restriction. This is the intraoperative image, and the postoperative CT and the postoperative MR confirmed the tumor was totally removed. Now the patient was stable and recurrent in the good condition, and with no new neurologic deficit. The third patient underwent 5 resection for melanoma and 2 courses of radiotherapy. The major complaint is this time the major complaint is progressive orbital mass associated with the severe headache. The patient has lost the visual in left side. This is the propertive MR. A review of the tumor involves the temporal muscle, orbital, eye bone, extraocular muscle, and the cavernous sinus. We can see the tumor encircling the cavernous segment of the ICA. And we also can find some partial of the tumor grows into the nasal cavity. So we also have reconstruction the 3-dimension structure, and it shows extended bone destruction of the anterior scan base. So in this operation, we're using a coronal incision. We perform a more complete resection of involved orbital and middle cranial fossa, and remove the eye bones. Considering the unclear restriction near the cavernous sinus, a small piece of the tumor within the sinus was not a resection. So after resection, we're using a microcutaneous free flap to reconstruction of the residual region 1 and region 2 scan-based diffractor. The post-operative pathology indicates the anaplastic malignant melanoma and the tumor with third mutation. And this is a post-operative CT scan at 3 months later, and suggests the tumor was essentially removed. And we can see the flap integrates very well with no immediate complications. But however, a long-time follow-up is necessary for detect any daily defect or recurrence. And now we will show the final patient. This is a 64-year-old male who complained of the numbness of the maxillary and decreased visual in the left side. And this patient with past the medical history of the adenocarcinoma of the colon. And this is the preoperative MR, show the tumor involves the orbital, the nasal cavity, the triangle plantar fossa, and the cavernous sinus, and with partial tumor dural involvement, and the tumor also in case the ICA. And this is the intraoperative image. We perform an en bloc resection of the tumor and involved IBAN. The post resection, the open dural and nasal cavity was also repaired using the ALT free flap. And this is post-operative CTA. And MR show the tumor removed totally, and this is the patient's post-operative appearance. Demonstrates the ALT free flap can maintain the overall visual appearance and contail very well. So this is the short time outcome of our cohort of patients. We can see after using frame flap technique, only one patient experienced post-operative infection. But because most of our cohort is malignant, so some part of the patients have had a variety degree of the facial nerve injury. So at last we can inclusion. And first, we think in selecting patients, it is command to perform angiogram or even BOT to protect the ICA. And the second, we think the anterior lateral side frame flap is made stem for repair the lateral scum base defect. We usually use it to rebuilding the large size scum base defector. And last, but we think the most important, also the overall outcome of the malignant is not optic mistake. The use of the neurosurgical scum base technique can increase the possible of achieving tumor-free merging en bloc resection in extensive malignant of the maxillary and temporal bone. It's a potential to cure some subset of the patients. So this is my lecture. Thanks for your attention.
Thank you so much. So, Professor Tariq, and any comments from you?
Thank you very much, Dr. Kwan, for this very interesting presentation and the very impressive cases that you have shown. My first question is, what subspecialties or what teams do you involve? Looking at the scans, of these patients when they present to your clinic, or emergently in an ED with epistaxis, or some sort of presentation, either an outpatient or referrals. What are the teams like involved in making the decision, either having an invasive procedure, surgery, or related to going to radiation or oncology? Thank you.
Thank you for your question. Because we can see the scum base malignant may involve some part of the some part of the range. So in this this type of the tumor, we manage our management were involved like department of the neurosurgery, department of the oral and the maxillofacial server, and may from the some department of the radiology, department of the tumors. So sorry, department of the knowledge. So we take part MDT to discuss the patient condition and desire the approach of the surgery and the subsequent of the plan of the radiotherapy and the chemotherapy.
Perfect. Perfect. And I want to congratulate you on the, the post-op scans that you have achieved. I see, very, very radical resection of the tumors and very well, good reconstruction. So my question, when do you see in these patients, the risk for the free flap or the reconstruction that you did is a high risk for failure? When do you see that? And when you decide or you foresee that, do you go for the surgery or do you, during your MDT, you think the surgery might go well, but the reconstruction is a high risk for failure? So what are your options with your colleagues then?
I agree with you. Some tumors extend to several range of the skin base. It's usually involved with some very important structures such as the jugular bulb, such as ICA, and it seems hard to resect totally because it means if you cannot unblock resect some malignant, it means it will recurrent soon. So in this patient, we need to design a very extended approach to cover the extended resection, more than 1 centimeters of the margin negative, and then if we can resect some important things such as ICA or such as jugular bulb, some tumor involves the capital sinus. This radial piece of the tumor can treatment by the radiotherapy or chemotherapy, and we also can find some target drugs to treat this part of the tumor.
Fantastic lecture. Thank you, Dr. Kwan.
And thank you, Dr. Kai, for your quick presentation. And we'd like to ask about the practice in Masan Hospital. So I would like about, so you mentioned there's one-stop reconstruction. So can you share with me, how do you divide the work during the surgeries with different team members, and how long would one surgery would take usually for this type of major operations? And and the second question is about because sometimes the problem is some of the tumors are malignant and they need to subject to post-op radial surgeries. So do you encounter usually how long would you wait for the radial surgery after the operations? How long would you wait to start the radial surgery? And what happens if there are some, for example, after the radial surgery, maybe after 2 to 3 months, sometimes the wound might have dehiscence, and reconstruction would become quite difficult if the flap has some dehiscence. So how would you manage those patients? And my third question is about sometimes the tumor itself invade the facial nerve, and we have to sacrifice in order to achieve the complete resection. So in a situation like this, how would you approach with the whether you would consider to reconstruct the nerve, for example, facial nerve or other nerves? Yes.
Okay, let me see. The first question is how long during the operation?
Yeah.
You
How,
ask.
yeah.
Yeah. Uh, Usually, this large operation can spend 1 day. About we use about 3 to 4 hours to resect the tumor, and it need 3 to 6 hours to reconstruct the skin-based defector.
I see.
Because we need to harvest the foreign flap and perform anastomosis to we usually to bypass to the STA and the external jugular veins. It will spend some time to do this work.
I
Okay.
see.
And the second question is how long the patient underwent the radiotherapy after the operation. We think the advantage of the foreign flap is it can support it can support enough the blood, so it can it can cure the more faster than the usually we not use this technique. So in our cohorts, all the patients can underwent the radiotherapy after 1 hour. Sorry, one month post operative. Okay, and I have forgot the last question.
Oh yeah, the third question is about sometimes you have to sacrifice the nerve, for example, facial nerve. So would you reconstruct the nerves?
Sacrifice
Nerve. For example, facial nerve. 就是
facial
神经线，就是比如说面部神经线，
OK
你要切掉的时候要怎么样？
sometimes we have to sacrifice some part of the visuals. So it's at first we need to resect the reach more than 1 centimeters of the negative margin, and we need to the margin more the tissue include the fat and the muscle tissues the flap to the restriction this part of the defector.
Okay. Dr. Kwan, how do you follow the free flap after surgery? Like, what's your protocol? Do you, some institutes use Dopplers, some institutes use, how do you follow the vitality and the viability of the reconstruction that you have done after surgery?
Because we perform free flap restriction, the patient can remove the his head. So usually the patient need to stay in ICA for more 4 to 5 days. Okay, and there is some question we can we can check the flap. If the flap is something wrong, if the way our anastomosis is suffers the stroke and suffers the flap the hematomas. If the complication of the flap we can find it. We need to perform a reoperative to deal with it.
May I ask if there's any further questions? If no, then I think it comes to the end of our presentation, and we are so glad that today we have two very educational lectures from the basics of the neuroangiography by Professor Musayadi and also Dr. Cheng for your one-stop reconstruction and really fantastic presentation. I would like to congratulate to two of you for your great work, and I'd also like to thank the chairs today, Professor Louis and also Professor Terek, for your help, and your comments are very important and very educational. So on behalf of the Educational Committee of ACNS and the President, Professor Pato, I would like to thank both the speakers of today, Dr. Poria Musayadi and Dr. Chuan-Kai, as well as the chairs, Dr. Mohan Nurik and Dr. Terek, for the time and the support for the ACNS webinars. A special thanks to Professor Xu for broadcasting this webinar on the WeChat channel. And today we have totally around 340 viewers on both the YouTube and WeChat channel. And special thanks to my co-host Roger and also Adore Liu for joining me today. And I would like to thank you all of you for joining me, and I hope to see you again tomorrow.